Hi, everybody. This is Dr. Brett Talley Daniel, MD, and I'm a neurologist and headache doctor and a member of the American Academy of Neurology and the American Headache Society. This is podcast number 14 on the migraine subject, and today's going to be a talk about when to start preventative therapy for migraine. Well, this is always a big question, problem, office managed migraine patients, because most people don't want to take a daily drug, which is what preventative therapy usually is. This is also called prophylactic treatment. So it's an intention where the doctor wants his patient to take a daily drug to reduce the intensity and the frequency of their migraine headaches. And this really should be considered a drug trial, and the patient should be asked to log their headaches in a diary and use the drug for 6 to 8 weeks to judge results and possible improvement, or no response for their migraine headaches before giving up that specific drug. Most patients want to take it 2 or 3 weeks, see if it works, but there's enough time. I always encourage them to try to go 6 to 8 weeks and log this, see how it goes. So the question for this talk is when to start preventative therapy for migraine. And preventative therapy should be considered for patients who, then I have a long list of statements or other things that come in there. So it should be for patients who experience 3 or 4 migraines per month. Well, years ago, the American Family Practice Group recommended that number, 3 or 4 migraines a month. The patients having that many, they should consider going on a preventive drug. And I'll say that to patients time and again in the office if they come in and they're having severe migraine. I'm kind of non-committal about it at that point of view. And if they don't want to take it, that's okay. But if they're having 7 to 10 severe migraines a month, it's really impacting their life. I become more vigorous and emphatic in discussing with them, stating it would be something they should consider. All right, it should also be considered for patients who have what's called chronic migraine. It's just a numbers game. The International Classification of Headache says chronic migraine is 15 headache days a month, 8 of which have migraine features. And migraine features are a severe headache on a scale of 1, anything over 5, like 7 or 8, 9, 10. Headaches that may usually be one-sided, associated with sensitivity to light, sound, and odor, throbbing, and disabling. So they go to bed, can't get up, can't go to work. It also should be considered for patients who present with medication over his headache. Well, medication over his headache is the main work that headache doctors do. So 80 to 90% of patients who come see a headache doctor for treatment have medication over his headache, which is a syndrome usually found in patients with migraine. They probably have it if migraine type headaches, as discussed earlier, but they may not think they have migraine or know they have. And many patients don't want to admit that. And so they are taking drugs like over-the-counter medicines like caffeine, a lot of that per day, Tylenol, Advil, NSAIDs. They could be taking an opiate narcotic like Tramadol or hydrocodone, or the worst drug in the world, butalbital, which is a barbiturate drug. Those patients should be considered for preventive therapy. It should be considered for patients who prefer that kind of treatment. But a lot of patients are glad that doctors have medications we can give to reduce a headache, and they'll willingly go in to try to treat it because they know the migraines are so bad. It should also be considered for patients who have significant pain that hamper their lifestyle. It should be considered for patients who take a lot of the over-the-counter, narcotic, opiate, or barbiturate drugs. It's for patients who don't get enough relief from acute therapy medication they're currently taking. So a lot of times, if you can drop the numbers of headache down, then acute therapy treatment, which is usually going to be a trip-in, works better. And it also should be considered for patients who have side effects from the drugs they're using in acute therapy. Okay, I have related questions to go along with this. So preventive treatment might not be an option for patients who, and I've got another list here, so who should take this? Well, patients who can control their headaches with an anti-inflammatory drug like, say, caffeine, Roxen, ibuprofen. They take their triptans, they're not over-treating, they're not having chronic migraine or medication with headache. They kind of get by with that. So they probably can get by not doing a daily drug for preventive therapy. It's also for patients who have other health considerations that don't allow them to take a preventive drug. They might already be taking a drug that wouldn't mix well with any preventive drug they should take. It's like patients who are being treated with a beta blocker or high blood pressure or some heart condition shouldn't be considered given Inderal for migraine prevention. It might be considered in patients who prefer treatments that don't involve taking medication. There are such things. It should be patients who can get relief from exercise, relaxation therapy, stress management, biofeedback, cognitive behavioral therapy, seeing a psychologist to deal with stress. They can be considered for patients who prefer a medical device like one called Cefaly, CEFALY, which is an FDA-approved treatment for migraine prevention, and is worn on the head and delivers electrical impulses that's used once a day for 20 minutes. Or some patients may want to try another device like the gamma core vagus nerve stimulator, which works for acute migraine treatment. The device gives a little shock in the neck, blocks migraine. It should be considered not to give the patient these medications, preventive drugs, if the patient's pregnant, because pregnancy, usually migraine gets better in the second or third trimester, and most physicians should be very careful adding any kind of medication to patients who are pregnant, in whom we only want them to take vitamins and iron, right? Okay, well, what are the American Academy of Neurology and American Headache Society recommendations for preventive drugs? I have a list here from them. Not me, it's from them. So the level A drugs, those that have been established as effective, and these are divalproex sodium, or sodium valproate, which is the old Depakote, Topamax, the generic, which is topiramate, which is short-acting, which you have to take twice a day or every 12 hours, or the long-acting drugs we take once a day, which is Trokendi XR or Qdexy XR. Provatriptan, which is a long-acting triptan lasting 26 hours, can be given menstrual-related migraine short term, like 4 or 5 days out of a cycle, because menstrual-related headaches are the worst headaches patients have. Another drug would be onabotulinum A, which is Botox, in which the patient injects 31 different little shots in patients' muscles in the forehead, neck. That's done every 3 months if it's successful. It's been indicated by the FDA for persons with chronic migraine, as mentioned above. But however, Botox has only been found to be modestly effective for preventing migraines in the most frequent sufferers. So it's been found to prevent 1.8 headaches a month more than placebos. I tell my patients, you want to every 3 months take 31 shots to get rid of 1.8 headaches a month. There you go. The next group of drugs would be beta blockers, such as metoprolol or propranolol or timolol. Okay, so those are the preventive drugs that are effective. That list of groups are level B drugs, which are probably effective. This is amitriptyline, nortriptyline, and venlafaxine, or antidepressant, anti-anxiety drugs. Then there are level C drugs that are thought to be possibly effective, and these are ACE inhibitors like lisinopril, angiotensin receptor blockers like candesartan, alpha agonists like clonidine, carbamazine, it's an old-time seizure drug, cyproheptadine, atenolol, and guanfacine. Now, there's special considerations of treating this group of patients because all this list of drugs above for prevention may reduce headaches significantly. However, there's special considerations for patients with multiple medical problems for using these drugs, like patients who are anxious and can't sleep, depression, could be given amitriptyline or nortriptyline, which really helps. In fact, I always told my patients that amitriptyline is the go-to drug for patients who have limited funds or no insurance, because it's only about $3 or $4 a month in Dallas, where I live. It's cheap, it's effective, can help people sleep at night. Persons who have epilepsy and migraine and overweight should be offered topiramate. This drug shouldn't be given to patients who have a history of kidney stuff. So you could get a 2-for-1 treatment there with topiramate. Or patients with tremor, hypertension, or migraine can be given a beta blocker, which may treat all 3 conditions. Thinking this way, the doctor patient may get double treatment effect with single preventive drugs. Now, here's the update on CGRP drugs. As far as I know, at this time, I'm dictating this March 4th, 2000. There's no data from the American Academy of Neurology, the American Headache Association on the new CGRP drug for migraine prevention. they've been listed and brought out by the FDA, but we don't have any articles written about them. So I'm talking about Aimovig, Ajovy, and Gality. It's well known these drugs work well and better than old-time preventive drugs, as I talked about above. But to see what happens long-term, we're going to have to see long-term studies, and that'll be other research papers. So stay tuned for new data on the CGRP drugs for preventing migraine. Right now, see all my articles at drmigraine.com on all those 3 drugs if you want to read about them, Aimovig, Ajovy, and Gality. All right, that's all at drmigraine.com. Thank you very much. Be sure to subscribe to my article here so we can follow each other. God bless you, all your migraine patients. Hope you're doing well. Bye-bye.